All right, everybody. I'm Mary Beth Hamfree. I'm the section chief of rheumatology at the University of Oklahoma College of Medicine. And today we're going to be talking about antiphospholipid syndrome. And these are our learning objectives. So we'll describe the clinical manifestations of APS, antiphospholipid syndrome, understand the risk and predictors of thrombosis with patients that have autoantibodies against the antiphospholipids, apply the evidence to choose the most effective anticoagulant for the treatment, describe the implications on family planning and pregnancy management, evaluate the patient with features of catastrophic antiphospholipid syndrome, and then actually, I don't think we're going to review the updates on the non-criteria antibody testing. So what is antiphospholipid syndrome? So this is really, you can kind of think about it as four things that make up the word clot. So C is for clots, arterial and venous. So this is not just venous clots, it's arterial clots. L is for livido reticularis, which is a particular rash that you can see, or skin finding that you can see. We'll see pictures of that later. O is for obstetric complications, and T is for thrombocytopenia. So that's clot. So antiphospholipid syndrome is really a clinical diagnosis, and it requires some clinical symptoms. So usually there has to be one or more arterial or venous clots. So arterial clots can be something that causes limb ischemia, finger ischemia, pulmonary embolism, stroke, kidney infarcts, and venous is obviously, the venous clots. And then you can have, for female patients with antiphospholipid, they may have significant pregnancy complications and fetal demise. The laboratory criteria for antiphospholipid syndrome is that you have to have one or more of these antiphospholipid antibodies, and they are, let me just move my thing. There's antibodies such as, let me get my pointer on. So there's lupus coagulant, which is a very specific antibody, and we'll talk in more detail about it, but it has a very high rate of having these complications. So the lupus anticoagulant is the worst antibody to have. Then there's anti-beta 2 glycoprotein antibodies, and they're kind of intermediate. And then there's anticardiolipin antibodies that still can cause these symptoms, but do so at a lesser rate. So there's several criteria that are designed by this International Society of Thrombosis and Hemostasis. And the laboratory criteria include one or more of these antibodies. So we talked about the lupus anticoagulant, anticardiolipin antibody, and you'll see they gave cutoffs. So if you order these labs, there will be a level, and it has to be in these higher levels for them to be at a level enough that would cause thrombosis or clotting. And then again, the anti-beta 2 glycoprotein 1 antibody. And again, these have to be high titer. Sometimes you'll see patients with low titer of these antibodies, and when you repeat them, they're still low titer, and that actually doesn't fit the criteria. So you have to have one or more of these antibodies, and then you have to have either an arterial thrombosis, venous thrombosis, or small vessel thrombosis. And then you have to have some kind of, if you're female, you can have an OR. And the pregnancy-related morbidities are that you have unexplained miscarriage at greater than 10 weeks. So this is usually in the second trimester. can be in the third trimester, and you have sudden fetal loss. The second kind is that you have premature birth before 34 weeks. And this is usually due to eclampsia or preeclampsia or placental insufficiency because the placenta gets a lot of clots in it. And then the third way that you can meet this criteria is if you have 3 or more consecutive miscarriages in the first trimester. So it's not uncommon for women to have multiple miscarriages in the first trimester, but usually they're not consecutive, and they may have a normal pregnancy in between some of the miscarriages. So this is 3 or more unexplained consecutive miscarriages. So the pathophysiology of antiphospholipid syndrome requires basically hematological or hemostatic reactions, and then followed by cellular elements, and then followed by complement activation. So the schematic here shows what's happening in the blood. So let's say that you have a B cell that's making antiphospholipid antibodies. And in this particular case, it's a beta-2 glycoprotein antibody. So the beta-2 glycoprotein can be on endothelial cells. It can be on the lining of the blood vessel. And then the autoantibody can come and recognize it. Once it's been recognized there, then you have neutrophils that are moving along, and there's complement there, and the complement will see this antibody and will become activated. The neutrophils will then become activated because of this little area of developing clot, and they will basically have netosis. So they basically open up and they dump out all of their nuclear material, and it makes these very, very fine nets of debris, DNA debris, histones, everything else, which are very sticky. And so the nets that are made by neutrophils in many cases serve to help bind bacteria. So if there's an infection, they're binding bacteria and then kind of trapping them in these nets. But in other tissue injuries, they basically are dumping out all of this material, which is kind of like acellular glue, and it will cause platelets and other cells to get caught in this netosis. So at this little nidus, you then end up having the netosis with red blood cells and white blood cells and platelets that are getting caught, and that can lead to an actual clot in the blood vessel. And if it's in the placenta, then it can lead to basically problems with the trophoblasts, and you get complement activation and then netosis around the trophoblasts, and that leads to degeneration or apoptosis of the trophoblasts, so the placenta becomes insufficient. So that's the initial pathogenesis with the antibodies recognizing phospholipids, and then you end up getting activation of neutrophils because of the tissue injury on the endothelial cells, which leads to netosis and clotting. And so, basically, depending on where this is happening in the body, you can get inflammation. You can get vasculopathy, which would be like the livedo reticularis we'll talk about in a minute. You can get the thrombosis, and then the pregnancy complications. And if you guys have any questions, feel free to, I can't see the thing, but if somebody wants to tell me, if you have a question, please feel free to ask. All right, so the antiphospholipid antibodies that we can test for include many. So there's the anticardiolipin antibodies, and this is usually done by an ELISA. So there's some antiphospholipid antibody that's attached to a plate, for instance, and you put the patient's serum on it, and the antibodies will bind to that antiphospholipid antibody, and then you put some kind of a detection that will determine how much antibody is there, and it's usually either a fluorescent readout or some kind of a coloremic readout. And then there's the lupus anticoagulant, and so this is usually detected initially by just getting a PT, PTT, INR on the patient, and they will have a prolonged PTT. So it will look like they're anticoagulated, like if they were taking heparin, but they're not anticoagulated. They're actually procoagulant. So it's a misnomer. And you can, if there's a prolonged PTT, you can order the lupus anticoagulant, and the lab will do a mixing study where they'll take the patient's serum and they'll add in some normal serum, and they'll look to see, does it correct the PTT, and if it doesn't correct, then that means that there is a lupus anticoagulant. Another antibody is the beta-2 glycoprotein 1 antibody, and again, this is an ELISA. Another test that is really cheap and easy to get is a VDRL, which is a syphilis test. And so this is called a false positive syphilis because it actually is indicating that you have a lupus anticoagulant most often. And then you're supposed to have one or more of these antibodies at least 2 times 12 weeks apart. But there are some very good researchers in this area that follow thousands of patients with antiphospholipid syndrome, and they check their antibodies every time they come to clinic, which could be 2 or 3 or 4 times a year. And there are some patients that their antibodies are always positive. There's some patients that they'll be positive one time, but then the next time they're not, and the next time they are. So, this requirement for 12 weeks apart, I would say can be a little bit loose if the patient, especially if they have a lupus anticoagulant, and they're having any of those other clinical manifestations. So, and sometimes people will present with catastrophic antiphospholipid syndrome, which we'll talk about in a few minutes, and that may be their very first event. They still have antiphospholipid syndrome, even though you don't have a chance to get a 12-week follow-up test. Okay, so the lupus anticoagulant, like I said, is a misnomer. So it's not always associated with lupus. I think it was first described as a condition that was associated with lupus, systemic lupus erythematosus. So it became known as a lupus anticoagulant. It's the primary antiphospholipid antibody that we see with lupus or without lupus. And you can have a lupus anticoagulant in other autoimmune diseases. You could have it in RA, rheumatoid arthritis, or other diseases. So primary APLS is having this antibody with no autoimmune disease. Secondary antiphospholipid syndrome is when you have it with lupus or an autoimmune disease. So, and as I said, this is not actually an anticoagulant. It just makes it look like you have an anticoagulant because you have a prolonged PTT. And so it is a procoagulant condition. So this is an example of the mixing study. So we have the patient's blood that has the abnormal antibodies in it. And the little blue things here are the phospholipids. And so some of these antibodies are binding the phospholipids, and that's leading to the prolonged PTT. If you put normal serum in, there's no antibodies, but there's now fresh phospholipids. And if if there were new with these fresh reagents or fresh clotting factors in here, it should correct if this is not an antibody. But if it's an antibody, the remaining antibodies will bind the rest of these things, and you still have a prolonged clotting time. A normal patient that doesn't have antiphospholipid antibodies, but maybe has an anticoagulant, you add new clotting factors with the normal plasma, and you correct it. So that's the difference between an abnormal clotting mixing study and a normal mixing study. This tells you there's an inhibitor in the patient's serum that continues to inhibit clot, or in this case, inhibit clotting, even though there's fresh clotting factors there. All right, so the types of antibodies that can be antiphospholipid antibodies. There's several kinds of antiphospholipid antibodies. It seems to grow every year. So we know that there's phosphatidylserine and prothrombin antibodies. There's anti-annexin 5 antibodies. Annexin 5 is actually something that is a antigen on the surface of cells when they're apoptosing. So you could see that if you had a little area of tissue injury and maybe there was an endothelial cell that's apoptosing, it may put a little annexin 5 out on its surface, and now the autoantibodies can recognize it. You can also have antibodies to vimentin, phosphatidylethylamine, phosphatidic acid, phosphatidylserine, phosphatidylinositol, and then you can have IgA antibodies against anticardiolipin and anti-beta-2 glycoprotein, and then beta-2 glycoprotein 1 domain 1 IgG. So these antibodies, you can have one or more of these antibodies, and most of these up here are going to be IgG or IgM antibodies. But you can have, if you have a high titer IgA antibody, it can also cause disease. So certain antibodies have certain clinical manifestations. So the antiphosphatidylserine prothrombin antibody causes thrombosis. The annexin 5 antibodies cause thrombosis or pregnancy complications. The vimentin cardiolipin antibody complex causes arterial thrombosis. Phosphatidylethylamine causes fetal loss and/or thrombosis. And then all of these here are at high risk for fetal loss. And then the IgA antibodies for thrombosis. And again, the beta-2 glycoprotein domain 1 antibodies, thrombosis or pregnancy complications. So depending on what your patient has, you can have a best guess at what their complications may be, which can help you decide on what therapies they need to be on, which we'll talk about. So what is the actual risk of thrombosis with antiphospholipid? So this is a cohort of 98 patients that were followed prospectively for 25 years. Okay, so this is a long study. And the annual rate of first thrombosis was 2.3% per patient year. So, basically 2% a year, whereas the normal population is less than 1%. And then by 15 years, the cumulative risk of the first thrombosis was, so here's 15 years here, was around 30%. So the longer they have the disease, the more likely they are to have clotting. But it's not it's not a real steep line for most patients. It's a 2% per year. So what are some of the partners, complement proteins and clotting factors that combined with APLS? So you can have beta-2-glycoprotein, human prothrombin, activated protein C, endothelial protein C receptor, protein S, tissue plasminogen activator, thrombomodulin, and then factors 12, 7, and 7A. So those are all part of the coagulation cascade, and they can be interacting partners with the antiphospholipid antibodies. We've already talked about the annexin 5 that can be on apoptotic cells. Oxidized LDLs can also contribute to APLS, and then complement H and C4b can also be associated with the antiphospholipid antibodies and the phospholipids. So when we think about what the risk is, we've already talked about certain antibodies can have a higher prediction for thrombosis versus obstructive complications or arterial complications. So what if you have a triple positive antibody? Okay, so what is a triple positive antibody? So this tends to be patients that have lupus anticoagulant plus either anti-cardiolipin antibodies or beta-2-glycoprotein antibodies, any of those ones that we just saw on the last slide or 2 slides ago. So these patients have the very highest risk of having clotting. So they're going to be more likely to clot than that 2% a year. The moderate risk patients have an anti-cardiolipin antibody that's medium or high titer. The low risk patients have one antibody, and it can be either an anti-cardiolipin antibody or anti-beta-2-glycoprotein, but they're at the low moderate titer, so not at the real high titer. So again, we talked a little bit about the antiphospholipid antibody profile and how some patients always have a positive antiphospholipid antibody. So that's called persistent antiphospholipid antibody. Those people are in this high-risk group. Those that have an intermittent disappearance of their antibodies tend to be lower risk. And then patients that have other reasons to have clotting also are at high risk. So if they have underlying lupus, if they have traditional cardiovascular risk factors that would cause atherosclerotic disease, and heart attacks and stroke, that can increase the risk of thrombosis and arterial clotting for antiphospholipid. Patients that smoke have an increased risk of having clots. Having surgery, so during surgery, you're going to have a lot of tissue factor, part of the cascade, clotting cascade release. You're going to have antiphospholipids on the endothelial surfaces that are being exposed. And so you can end up developing a procoagulant during that time. And then OCP stands for oral contraceptive, so birth control pills. Remember that some patients, especially patients that get open heart surgery or have very large surgeries, can actually develop acquired factor 7 antibodies, factor 10 antibodies, and so they actually can become procoagulant from that as well. So there are other comorbid conditions other than autoimmune conditions, including pregnancy and having nephrotic syndrome from, perhaps IgA nephrotic syndrome, or other causes of nephrotic syndrome. And then anything that is going to cause genetic predisposition to having thrombosis, like the mutations in prothrombin 2210, so they become prothrombotic, factor V Leiden, etc. So this is the rash of livedo reticularis. And so you see these, it's a flat rash. You can't feel the skin, but you see these red circles. They're kind of coarse red circles. Some aren't completely closed, but most of these are. This one's got a little break there. And then pallor in the middle. So these are the medium vessels in the dermis of the skin. So they're not the superficial capillaries. These are the medium vessels deeper in the skin. And this indicates a vasculopathy. So we see this with anticardiolipin or antiphospholipid antibodies, lupus anticoagulant. We can see this as a manifestation of vasculitis, independent of antiphospholipid antibodies. But if you see this as a new condition that came on in adulthood, this tells you that there's something going on, either autoimmune or antiphospholipid, some kind of a vasculitis. Children can have this all the time, and there are some adults that have had prominent livedo reticularis their entire life, and that's not anything to worry about. It's usually the new onset. So sometimes patients with antiphospholipid can actually develop very difficult to treat leg ulcers from recurrent clots, arterial and venous clots. They can get thrombocytopenia from all the platelets being stuck in the netosis, and then they can get cardiac valvular abnormalities. So we'll look at that. So the digital ischemia that can happen. So when you get acute clotting, you can get this ischemia. So this is gangrene already. This is necrotic finger. And you can see that it's got this area of very black. It still hasn't opened yet. So, but once it opens, it'll probably be wet gangrene. And then here's the area of hyperemia. So there's increased blood flow here. Body's really trying very hard to get blood flow down to this ischemic digit. Same is happening here. So the tip here is pale. It's almost blue, purple. It's going to become black if we can't open up the blood vessels. And here's that area of hyperemia. So this is pretty typical finger gangrene that you can see with antiphospholipid syndrome. This is from an autopsy of a patient that had antiphospholipid antibodies and antiphospholipid syndrome. And these are the little vegetations of antiphospholipid antibodies and platelets and stuff that are stuck on the valves. So antiphospholipid syndrome can also affect the CNS. So you can get strokes, you can get TIA, transient ischemic attacks, or TIAs. You can get amaurosis fugax, so where your retinal artery is having a transient clot there. So the patient feels like there's a curtain that comes down over their eyesight, and then it may go back up again. They can get transverse myelitis. And remember, with transverse myelitis, patients it's usually somewhere in the thoracic spine, and the patients will have a band of very intense dysesthesia or paresthesia or pain. And then below that is where they'll start to get weakness and neurological symptoms. You can get Guillain-Barré, chorea, where you have unusual body motions. Migraines can be a symptom of antiphospholipid syndrome. and you can get a multiple sclerosis-like syndromes. It's not truly multiple sclerosis where you have B cells and the same pathophysiology, but it can mimic multiple sclerosis. Okay, so we mentioned earlier the obstetric antiphospholipid antibody syndrome. And again, it's 3 consecutive first trimester pregnancy losses, so under 12 weeks, or 1 late fetal loss. And so usually if there's a late term pregnancy loss in the 2nd or 3rd trimester, if the fetus is recovered, they'll do an autopsy to see if was a genetic reason. They had 3 different, 3 chromosomes or something, or had a heart valve or something wrong with them. And if they can't find any reason for the baby to have died, then that would meet the criteria. The severe prematurity and preeclampsia due to vascular insufficiency of the placenta. And again, this is before 34 weeks. And then antibodies, especially the lupus anticoagulant, has the highest risk for fetal loss. If you have antiphospholipid antibodies and you have 1 episode of preeclampsia or eclampsia or fetal loss, it's not 100% that you will have another, but you are at very high risk for having the same outcome. Okay, so what are the treatments that we use for antiphospholipid syndrome? So it's really anticoagulation is the only thing that works. And unfortunately, this is lifelong in most patients. So once they go on anticoagulation, they need to stay on anticoagulation. The type and dose of anticoagulation depends on the clinical manifestations. So if somebody is having arterial or venous thrombosis, then the best drug to use is actually still warfarin. So warfarin is a pill you take daily. You have to monitor the INR. And if the patient has venous thrombosis, you want their INR to be between 2 and 3. If they've had arterial thrombosis, it needs to be a little higher, between 3 and 4. So we usually shoot for something around 3.5. Sometimes patients either can't stay appropriately anticoagulated with warfarin for reasons that we don't understand, or they are therapeutic, but they continue to get clots. And if that happens, then we have to switch them over to heparin. And so we usually give them drugs like Lovenox, the daily shot of low molecular weight heparin. So then they're basically on lifelong heparin. There was great excitement when the direct oral anticoagulants came out because you don't have to monitor the INR. It's immediate anticoagulation. It works for so many other conditions, but it very early became very clear that these medications do not work for antiphospholipid syndrome, so do not use them. We still see patients that get referred to us that are on these medications, and they're always disappointed when we tell them that they have to stop them and go back on warfarin or switch to heparin. If the patient has obstetric antiphospholipid syndrome, so they've had 3 or more early losses, they've had a late pregnancy loss, or they've had eclampsia or preeclampsia, we put them on heparin and a low-dose aspirin, an 81 milligram aspirin. If somebody has just had the antibodies, and they've had the antibodies 2 or more times, but they haven't had any clots or any thromboses, then it's not really clear what to do. And so we see these patients in rheumatology because any patient we have that has lupus, we will check these autoantibodies to see if they have secondary APLS that we need to be aware of. And we'll find a handful of patients that have these antibodies. More often than not, they may have had a clot in the past. And so, we'll go ahead and treat them. But there are some patients that just have antibodies, but they have never had a clot. And there's been a lot of studies looking at whether or not you should put them on aspirin, whether or not you should put them on warfarin. And if they've never had a clot, it's hard to decrease never having had a clot. So it's really unclear. You probably are putting them at higher risk for bleeding from complications of warfarin or heparin than preventing clots if they've never had an event. So oftentimes we won't do anything. Sometimes if we're really worried about the patient, we may put them on low dose aspirin, but the literature, some literature suggests that that's helpful as primary prevention. Other literature says it doesn't make a difference. So I think we're really treating the physician when we put the patient on low dose aspirin. So now let's move on to catastrophic antiphospholipid syndrome, or CAPS. So this is a really devastating disease that I've probably seen 5 or 6 times in 20 years. And it's a really scary development of multi-organ dysfunction and clots. So the patient often will present with acute renal failure, and this is a glomerulus in the kidney. All of this pink frothy stuff here, this is antibody and clot. So there shouldn't be any of this color stuff here. So this is all clot. And if you see the same image and you're looking at the antibody deposition, all of this green stuff is the antibody deposition in the kidney. So just a tremendous amount of antiphospholipid antibodies there in the kidney. Over here, you can see that there's these areas of red blood cells that are caught in this pink frothy stuff. And this again is part of that, the antiphospholipid antibodies with microthrombi. So that's what this area is, microthrombi. And this is an EM of the microthrombi showing some of the platelets and antibodies and other stuff in here. So this is really a feature of thrombotic microangiopathy. And luckily, only about 1% of patients with antiphospholipid will develop catastrophic antiphospholipid syndrome. Some of the other manifestations of antiphospholipid CAPS is skin. So they can get, discoloration of their fingers, like we just saw a minute ago with digital gangrene. They can get profound livedo-reticularis. They can actually get skin infarctions, which will tend to be round with a central, it'll be an area of ischemia with a central ulcer that will then enlarge. They can get microangiopathic hemolytic anemia, so causing their blood cells to shear and break open. They'll get thrombocytopenia as a result of that. They can actually infarct in their bone marrow and get bone marrow necrosis, which will then lead to multi-lineage anemia, thrombocytopenia, etc. They can get strokes, seizures, encephalopathy. The pulmonary manifestations can be acute respiratory distress, but more challenging is the diffuse alveolar hemorrhage. So diffuse alveolar hemorrhage is where they get clots in their capillaries of their lungs, and then those start to break open and bleed into the lungs. And so that patient can lose units of blood into their lungs. And the only way this is diagnosed is by doing a bronchoscopy, where they go down and they squirt some saline and they pull back and they get a bloody amount of fluid back. They squirt some more saline down, they pull back and it's still bloody, or maybe even bloodier. They squirt some more, pull it back, and it's also bloody. So that's called progressive return of blood, and that indicates that something's bleeding there, and that's a diagnosis of diffuse alveolar hemorrhage. So that patients can also get the acute kidney injury, hematuria, proteinuria, and usually associated with that, they'll get very high hypertension. So that sometimes can be the first indication that something's going wrong, as they develop difficult to control hypertension. Cardiac-wise, they can develop systolic dysfunction, myocardial infarctions, the valvular lesions we saw earlier, atrial thrombosis, and then you can basically infarct any other part of your body. You can infarct your adrenal glands and then have adrenal crisis. You can infarct your kidney, your liver. You can infarct your bowel and get bowel ischemia. So the many manifestations. I would say CAPS looks a lot like severe sepsis. And so, probably some patients actually have CAPS, but are initially treated as sepsis, and some of those patients will go on and die, because we don't usually treat sepsis with anticoagulation. And that's really, you need anticoagulation here. It can be very challenging in the setting of the diffuse alveolar hemorrhage. They may be having clots everywhere else, but they're bleeding into their lungs, which can cause them to die. So that is where it's really challenging. And we move on to plasma exchange, or plasmapheresis, where we try to pull out the antiphospholipid antibodies from their bloodstream and replace it with normal, with other people's plasma, to try to get the bleeding to stop and the clotting to stop. And then if we can get the bleeding to stop in the lungs, after a couple of days, we can start anticoagulation again. So this can be a very challenging condition to treat. And so this study looked at a number of patients, and you can see over here that this is a percentage of patients that manifested these complications, and the number of patients here. So patients, once they have these abnormal endothelial or epithelial surfaces from clots and thrombosis, they can get infections in the respiratory tract, cutaneous, urinary tract. They can actually get sepsis, and then if they're having bowel infarctions and bowel problems, they can get gastrointestinal infections. Or these are precipitating factors. I'm sorry, I misread my title. So severe infections can precipitate CAPS. Surgery, trauma, or invasive procedures can as well. And again, surgery and trauma, all of these end up causing usually some epithelial or endothelial surface, or it could be muscle or other things, where there's a lot of tissue factor release. So you're getting a lot of coagulation happening at those wound sites, and that can trigger CAPS. Cancers can trigger it. Having an inadequate anticoagulation can trigger it. We already talked about the fetal and lupus flares, oral contraceptives. But about 35% of patients, we won't know what triggered their CAPS. So the differential for CAPS is pretty short, actually. So because these patients, so thrombotic thrombocytopenic purpura, these patients, the criteria for that are fever, renal insufficiency, mental status changes, low platelets, and anemia. And so you can see CAPS could definitely look like that, right? They may have hemolytic anemia, they may have thrombocytopenia, maybe they've had a stroke, or they have encephalopathy, and they have clots in their kidney. So it can be difficult to distinguish TTP from CAPS. Sclerodermal renal crisis, so can look like CAPS. But again, what would give that away is it's a patient with scleroderma. They have to have some findings of scleroderma to have sclerodermal renal crisis. Severe multi-organ lupus flare can look just like CAPS, and there we would be treating more for immunosuppression than we would with anticoagulation. And then disseminated intravascular coagulation that could come from sepsis or trauma or severe, tissue injury. All right, so unfortunately, 50% of patients with CAPS will die from their CAPS. We use heparin anticoagulation, intravenous heparin anticoagulation. We will use glucocorticoids to decrease the inflammation that may be going on. We use plasma exchange to remove the offending antibodies. We can give IVIG. An IVIG is one of these strange, it's basically intravenous immunoglobulin from a bunch of blood donors, and it's still kind of magical how it happens to work, but somehow by flooding the body with all these extra immunoglobulins, it is actually anti-inflammatory and it can help with CAPS. So we do that. And then you can also give them rituximab. Rituximab won't work right away, but it will decrease the B cells' ability to go on to become antiphospholipid plasma cells. So it won't get rid of the plasma cells they already have, but it will prevent the renewal of plasma cells that are making antiphospholipid antibodies. And then oftentimes, if the patient has lupus associated with CAPS, if they're really, really sick, we may also give them Cytoxan in addition to the rituximab, steroids, plasma exchange. All right, so I think that's all we have. I went pretty fast, I'm sorry. But if you have any questions, feel free to ask. Let me see if I can get this off. And I will unshare.
Okay, thank you for the lecture. And колеги, чи є у вас питання? Colleagues, please, questions. No, I can start. My question is, how common is antiphospholipid syndrome in general population?
Yeah, so it's not common in the general population. I think the numbers are probably well below 1%. So it's not common.
1%.
Less than 1%.
Less than 1%.
Yeah.
And if I understood, women is more common than men.
Yeah, and that may be because of secondary antiphospholipid syndrome, right? So lupus is 9 women for every 1 man that has lupus. And we know that lupus is a very high risk factor for antiphospholipid syndrome. So any of those women that have lupus are more likely to have, so there tends to be more women. And it may just be, there have been people we've seen that, men we've seen that had 1 clot, and they get treated with, anticoagulation for 3 months, and then they get another clot later. And for whatever reason, physicians don't tend to think about antiphospholipid syndrome in men. And so I think sometimes they're just, they check protein S and C and factor V Leiden and prothrombin 2210 and do that recurrent workup, but they don't necessarily send the antiphospholipid antibodies for some reason. And it's very rare that I see see a man sent to us that's actually had a lupus anticoagulant. I think there's a big bias of physicians in America to only order, well, most of the time they don't even order the lupus anticoagulant. They only order antiphospholipid antibodies. But the lupus anticoagulant is the one that has the highest risk factor. So if you only had money to order one lab, I would order the lupus anticoagulant.
Thank you. And Mary Beth, in our chat, we have question from Natalia Shevchenko. Could you check, please? It
Sure.
will be.
Okay, so is the positivity of antiphospholipid antibodies sufficient for the diagnosis of APS in children? So you can make, if they've had antiphospholipid antibodies twice, or they've had multiple clots, you can make that diagnosis in children. It's no different. And then including for the diagnosis of secondary APS yes. So again, if they have those antibodies and they've had a clot, well, if they've had those antibodies, you can at least say they're at risk for antiphospholipid syndrome. If they've already had a clot, then you can give them that diagnosis. Yeah, unfortunately, we do see children get this.
Thank you very much. Thank you.
Colleagues, questions, more questions?
So I think the main take home to remember is if it's arterial clots, you want to use warfarin or Coumadin at an INR of 3 to 4. But if it's venous clots, you can use the regular INR of 2 to 3.
Thank you.
Yeah.
Thank you, Mary
Okay.
Beth. It
Yes.
was very interesting for us, especially for a specialist that not often meet this
Yes.
syndrome or some rheumatological pathology. Yes, and I as an intensive care physician, yes, or maybe we should remember about this syndrome, and sometimes we could
Yes.
meet them. Yes, but we
Yeah.
forget about
Exactly,
this.
and I think-
Thank you. It was excellent
Yeah,
and
I
very
think we-
helpful for me.
Yeah, oftentimes the patients that we get called to see are in the ICU with multi-organ failure. And like I said, sepsis can trigger this, right? And so it's that patient with sepsis that is not getting better with the antibiotics, that they're still having organ dysfunction. I think that's where you would want to start to think about checking for antiphospholipid antibodies.
Yeah. Thank you.
Yeah. All right. Well, thank you so much for your attention today. And I hope you guys have a good remainder almost of November and stay well.
Yeah, thank you. And we hope on the new meeting with you. Thank
I
you.
hope. Bye-bye.
Bye-bye.
Thank you.